Okay, good evening and welcome to the 33rd International Congress on Pediatrics, the first day, and the pediatric updates and the updates on pediatric hypertension. My name is Dr. Mariam Bakhtiari. I'm a recently graduated pediatrician from Tehran University of Medical Sciences, and I have the honor to be here with you guys and to host this meeting. So we are more than honored, and I myself am really excited for this session of pediatric updates on hypertension. I have to have a special thanks to dear Professor Asadi for arranging this amazing meeting and inviting all of these lecturers. And I cannot wait to listen and to hear all of these amazing lectures. So a few points and notes. So make sure that you use your complete name and last name in the participant part. You have to rename yourself because the name that you're using in the participants is going to show on the certificate that you can obtain in our website. So make sure to change it to your actual name and last name. The other point is that please keep your microphones muted and also your videos to not disturb the lecturers and to not interrupt them. And as I told you that the video is live streaming on YouTube as well, and you can obtain it after this session is over on our YouTube as well. And about the CME credit and also the certification that you can obtain on our website. So for the website and the certificate of attendance, you have to register on our website, and then you can download your certificate of attendance after the Congress is over. And for Iranian audience who want to obtain a CME credit, you have to register in the CME website, ircme.ir. And then after the session is over, you have to participate in the exam, in the test that is provided there. And hopefully you will get the CME credit after that. Without further ado, I would love to start this session with an amazing clip introducing our lecturers. Okay, so for our first lecture, we're going to have dear Professor Farahnak Asadi. Just a second. Okay, again, sorry. For our first lecture, we're going to have a dear Professor Farahnak Asadi. He's a distinguished professor emeritus and the chief pediatric nephrology in Rush University of Medical Sciences, Chicago, Illinois, in USA. So, dear Professor Asadi, if you can hear me, we are more than honored to have you with us today, and we can't wait to hear to your amazing lecture. Dear Dr. Asadi, if you can hear me. Um, Dr. Asadi, if you can hear me, you are a co-host now and you can start sharing your slides and start your
But
lecture.
I can hear you very well,
Yeah,
but
we
I
have
don't.
your voice right now.
Okay, shall
And
I start?
yeah, just a minute. Let me ask to open your video as well, if you prefer.
My video
Yeah.
is
Oh,
open.
we're having you bright and beautiful. Good morning. I know that
Okay.
it's really early in the morning, so thank you.
Yeah. Good afternoon to you.
Thank you so much. Thank you. It's an honor to meet you.
Okay.
And it's really exciting to have you here with us.
My
So you
pleasure.
can start whenever you want. You're a co-host and you can share your slides now and start whenever you're ready.
Okay. Good afternoon. And thank you. Thank you all for your interest, taking the time from your busy schedule to attend the hypertension session for this, event. I would like to take this opportunity to thank you and thank Dr. Rabbani, who was the founder of this, prestigious organization. And with his wonderful dedication and direction over the last 30 years, he achieved a wonderful approach to the advancement of medical science across the globe. I would like also to send my special thanks to Dr. Agai Mogaddam and his wonderful colleagues and associates for getting together a team of prestigious, most talented speakers around the world. It is my distinct honor and privilege to be a part of this team. The panel of pediatric hypertension, in addition to me, include Dr. Hooman, who will be talking about the monogenic endocrine hypertension, Dr. Mohkam, who will discuss the resistant hypertension and refractory hypertension, Dr. Seyedzade, who will talk about his own experience and reports on the relationship between passive smoking and hypertension in Iranian school-age children. And then Dr. Malekan-Rad, who will talk about the cardiovascular induced hypertension. I'll be glad to start my first slide. Okay, my topic is,
Sorry, dear professor, we don't have your slides now.
you don't have it?
No, we don't see it.
Oh,
Did you share your screen with us?
I have it in front of me.
No, you have to press the green button down below. It says share screen
Oh, I
in
see.
the Zoom.
Let
Okay. And then after that, you have to choose your slides.
me see how can I go back to your screen. I lost your screen.
Oh my God. Don't lose us.
Let me see. Do-
Dear professor, if you want, I can
Okay.
share your slides.
I think you have a copy of my slides, don't you?
Yeah, I do have it. Yeah, I do have
Okay.
it. So I will
Why don't you
start
bring
now.
it up?
Yeah, just a second. And then whenever you wanted to go to next slide, just tell me next slide
Okay,
and I will go.
Okay.
Just a minute. Okay, so I think that you can see my slides. You can see your slides now.
Okay.
And you can start whenever you want.
Okay. As soon as I see my slides.
You don't see them now?
No.
Please close the PowerPoint file that you've opened on your desktop so that it might, you have to reopen, maybe you have to reopen your Zoom.
Okay. You want me to close my PowerPoint, right?
Yes, dear professor.
It is, okay, let me see that. Okay, it's done.
And can you see our screen now? Can you see yourself or me in the side of your...
No, I can't. No. I don't see you and I don't see your screen.
Dear Professor Asadi, hello.
Yes, hi.
Hi, sir. We can go just for a moment. We can go for our next lecture, and then we will be back with you. Is that okay with you? Thank you very much, sir.
Sure.
We will be right back with you, okay, Dr. Dear Professor.
Thank you.
Okay, so sorry for the inconvenience that happened. So our next lecture is going to be by Professor Malekan-Rad. She's a professor of pediatrics in the Division of Cardiology in Children's Hospital Children's Medical Center in Tehran University of Medical Sciences, and we are more than excited to hear her lecture. So she couldn't attend this meeting in person because she had clinic duty and she couldn't reschedule her appointments. So we have a pre-recorded session of hers that I will play in a moment.
Ladies and gentlemen, hello, good morning, good afternoon, and good evening, depending on where you are. First of all, I sincerely thank the distinguished Congress organizers and also Professor Asadi, the distinguished chair of this session. Today, we will talk about cardiovascular causes of systemic hypertension, effects of hypertension on the cardiovascular system, and obesity and obstructive sleep apnea as disorders that can produce both hypertension and cardiovascular disorders. Let's start by cardiovascular causes of systemic hypertension in children and adolescents. When we search medical literature for cardiovascular causes of systemic hypertension, we encountered this paper that was published in Pediatric Clinics of North America in 1993, and 6 conditions including coarctation of the aorta, arteriovenous fistulas, patent ductus arteriosus, aortic insufficiency, mitral insufficiency, Takayasu-Williams, and Eisenmenger syndromes were stated as cardiovascular causes of hypertension in the pediatric patient. As you know, today, we do not recognize mitral insufficiency and Eisenmenger syndrome as causes of systemic hypertension in the pediatric patient. As you see in this table that is taken from the latest edition of Anderson's Pediatric Cardiology, cardiovascular causes of pediatric hypertension is confined to coarctation of aorta, and thoracic or abdominal coarctation of aorta and Takayusu arthritis are included as subtypes of coarctation of aorta. And Mid-Aortic Syndrome and fistulas are considered as renovascular causes of systemic hypertension in children. Using the term middle aortic coarctation syndrome in this paper adds to the confusion on classification and separation of renovascular causes from cardiovascular causes. Overall, there is a significant overlap between cardiovascular and renovascular causes of hypertension in children in the literature. To simplify it, we discuss it as vascular causes of systemic hypertension today. We discuss 4 conditions. Number 1, coarctation of aorta. Number 2, renovascular hypertension. Number 3, middle aortic syndrome. We know that there is a significant overlap between number 2 and number 3. And number 4, Nutcracker syndrome. Coarctation of the aorta is a narrowing of the aorta that is classically associated with an upper to lower extremity blood pressure difference of 20 millimeters of mercury or more. What is the problem in coarctation of aorta is persistence of hypertension after repair of coarctation of aorta in a significant number of patients. In fact, 20 to 30% of children aged 7 to 16 years have persistent hypertension after successful repair of coarctation at a median age of 2 months without having any residual significant aortic arch obstruction. In order to explain this finding, selfish brain hypothesis has been proposed. This hypothesis states that vertebral artery hypoplasia with an incomplete posterior circle of Willis are responsible for this finding. In fact, this hypothesis suggests that brainstem hypoperfusion evokes hypertension to maintain cerebral blood flow, and this is why this hypothesis is called selfish brain hypothesis. To examine this hypothesis, Dr. Rodrigues and his colleagues from United Kingdom examined vascular anatomy of the brain in 127 patients after repair of coarctation with 33 normotensive control subjects. They found that vertebral artery hypoplasia and incomplete posterior circuit of Willis were significantly more common in patients with persistent hypertension. Therefore, they concluded that vertebral artery hypoplasia and incomplete posterior circuit of Willis were independent predictors of persistent hypertension after repair of coarctation. The next item is renovascular hypertension. Renovascular hypertension is characterized by elevated blood pressure caused by kidney hypoperfusion. That's generally because of anatomic stenosis of the renal artery. What are the red flags for renovascular hypertension? There are 10 red flags for renovascular hypertension. Number 1 is whenever we have very high blood pressure, we should suspect the presence of renovascular hypertension. Number 2 is when we have secondary symptoms of high blood pressure, such as cerebral symptoms, cardiac failure, or facial palsy. Number 3 is when we have a hypertension that is not controlled with 2 or more antihypertensive drugs. Number 4 is when our patient has a syndrome with a high risk of vascular disease such as neurofibromatosis, tuberous sclerosis, Williams syndrome, or Moya-Moya disease. Number 5 is when the patient has signs of vasculitis, for example, Takayusu disease. Number 6 is when the patient is a known or suspected case of previous vascular insult, for example, renal artery thrombosis or umbilical artery catheterization, or previous trauma or radiation. The next one is when the patient has transplanted kidneys. And the 8th one is when we hear bruit or brute over the renal artery or renal arteries. And the next one is when the patient has elevated peripheral proximal renin or moderate hypokalemia. And the last one is when the patient develops abrupt fall of GFR after the administration of angiotensin-converting enzyme inhibitors or angiotensin receptor blockers. Renovascular hypertension can be further classified into 5 categories. The first one is fibromuscular dysplasia, that is the most common subcategory. The second one is when we have renovascular hypertension in association with other syndromes such as neurofibromatosis type 1, tuberous sclerosis, Alagille, Williams, Marfan's, or other syndromes. The third subcategory is when we have renovascular hypertension due to vasculitis, such as Takayasu disease, polyarthritis nodosa, Kawasaki disease, or other systemic vasculitis. The fourth category is extrinsic compression by tumors such as neuroblastoma, Wilms tumor, or other tumors. And the last one, or miscellaneous causes or other causes, are radiation, umbilical artery catheterization, trauma, congenital rubella syndrome, transplant renal artery stenosis, and idiopathic arterial calcification in neonates. Takayasu arthritis is a granulomatous, chronic, relapsing, and progressive panarthritis with high mortality if undiagnosed, timely, and untreated. It has unknown etiology, and it can affect aorta along its length and its main branches. It can also involve the pulmonary and coronary arteries. Takayasu arthritis occurs in two phases. The first one is early pre-pulseless systemic stage, and the second one is late occlusive stage. Hypertension occurs in the late occlusive stage, and this first stage, that the patient has non-specific and systemic symptoms, causes delay in diagnosis. There are 8 red flags that should raise suspicion to the presence of Takayasu arthritis in any patient younger than 40 years of age. Number 1 is unexplained raised ESR and or CRP. Number 2 is carotidemia. Number 3, hypertension. The next one, discrepant blood pressure between the arms, more than 10 millimeters of mercury difference. Number 5 is absent or weak peripheral pulse or pulses. And the next one is limb claudication. Number 7 is arterial buoy or brute, and the last one is angina. The next condition is Mid-Aortic Syndrome or Middle Aortic Syndrome. Mid-Aortic Syndrome is a rare condition that is characterized by a stenosis of the abdominal aorta, with or without the involvement of branch vessels. Patients typically present with hypertension due to decreased renal perfusion, but less common presentations include renal insufficiency, heart failure, claudication, stroke, and abdominal pain. Middle aortic syndrome may be idiopathic, that is the most common type, or may be genetic, or may be associated with a variety of diseases that have a significant overlap with conditions that produce renovascular hypertension. The last vascular cause of systemic hypertension in children is Nutcracker syndrome, or left renal vein compression syndrome, or left renal vein hypertension syndrome. The entrapment of the left renal vein between the abdominal aorta and superior mesenteric artery is commonly referred to as Nutcracker syndrome. If this entrapment is without any symptoms, that means if it is asymptomatic, then it is called Nutcracker phenomenon. The two most common symptoms of Nutcracker syndrome are left flank pain and exercise-related hematuria. Other symptoms include varicocele, orthostatic proteinuria, and anemia. The presence of persisting severe varicocele or intermittent macroscopic hematuria should raise our suspicion to the presence of Nutcracker syndrome. In one study, varicocele was found as the first sign of Nutcracker syndrome in 1/3 of children. In the second part, I will talk very briefly about cardiovascular consequences of primary hypertension in children and adolescents. Hypertension can adversely affect cardiac structure and function and also vascular structure. It can produce left atrial enlargement and left ventricular hypertrophy and decrease left ventricular relaxation and compliance. Also, it can produce atraumatous changes in the vascular system in addition to arterial stiffening, endothelial dysfunction, and increased carotid intimal medial thickness, and also decreased cerebrovascular reactivity. In the third part and in the last part, I will talk about two of the causes that produce both systemic hypertension and cardiovascular disorders in children and adolescents. They are obesity and obstructive sleep apnea. Now we will talk about obesity-associated hypertension very briefly. As you know, obesity is the leading cause of secondary hypertension in childhood. As you see in this diagram, obesity and obstructive sleep apnea can both produce cardiovascular disease and hypertension. Obesity can produce obstructive sleep apnea, and both obesity and obstructive sleep apnea can produce endothelial dysfunction, and endothelial dysfunction increases the risk of hypertension. Obesity is characterized by a chronic low-grade pro-inflammatory state. In obesity, we have hyperplasia and hypertrophy of fat cells that leads to imbalance in the release of adipokines. In obesity, we have an imbalance in favor of bad adipokines. As you see in this slide, normal fat produces anti-inflammatory adipokines that have cardioprotective effects. In contrast, when there is obesity, dysfunctional fat produces pro-inflammatory adipokines that damage the cardiovascular system and produce cardiovascular disease. Furthermore, there's a crosstalk between skeletal muscle and adipose tissue. Irisin, that is a myokine that is secreted from the muscles due to exercise, inhibits the effects of pro-inflammatory adipokines and results in decrease in blood pressure. Finally, obstructive sleep apnea can produce systemic hypertension and ventricular dysfunction through several mechanisms, including arousal, hypoxia, and increased intrathoracic pressure. Conclusion: coarctation of the aorta, Mid-Aortic Syndrome, renovascular hypertension, and Nutcracker Syndrome can produce systemic hypertension in children and adolescents. Obesity and obstructive sleep apnea can produce cardiovascular disorder and systemic hypertension. Dysfunctional adipose tissue play a significant role in producing hypertension and cardiovascular disorders in obesity. Thank you very much for your attention.
Okay, we have to thank dear Professor Malekan-Rad for her amazing lecture. It was really unfortunate that we couldn't have her live on our session, but really enjoyed her lecture on secondary causes of pediatric hypertension. And we thank her. And she's going to be online with us in a few minutes. So if you have any questions, you can ask in the chat section, and she will be available in the chat for Q&A. So dear Dr. Asadi, I can see that you have started to share your screen. Just we can't hear you. You have to open your microphone again as well. Dear Professor, we don't have your voice. If you can
Do you
please.
have my voice?
Yes.
Okay.
Awesome. Yes.
So I like to see, how to share.
Okay, we were seeing your slides just in a few moments ago. I think you've opened them. Just open your slides right now because we can see your screen right now. Yes, we can see them. So maximize them and put on slideshow.
Okay, so that's cool. So then I am ready to go now, right?
Yes, just put them on slideshow and we are ready to go. Awesome.
Okay, great. Good afternoon again. My topic today is inherited disorders of endocrine hypertension. What I'm going to do today, I'm going to just provide you a very, very simple and practical approach to pediatric hypertension. As you know, hypertension is a significant cause of cardiovascular, cerebrovascular, and kidney mortality and morbidity if untreated. Causes of hypertension vary by the age. In children older than 6 years of age, essential hypertension is more prevalent than glomerular disease or secondary hypertension. Whereas in children younger than 6, secondary hypertension, including glomerular disease, renal vascular hypertension, renal structural abnormalities are more common. Overall, 75 to 85% of children younger than 6 years of age, if they present with hypertension, the hypertension is secondary. Next slide.
Dear Professor, you have to forward your slides, but there seems to be an error in the downside of your screen. So maybe you have to address that first.
Alert from System UI server. Low battery.
Oh, and the battery is dying again.
Alert from low battery.
Okay.
Yeah.
So let me see, where is the arrow? I don't.
No, error.
Okay.
There's an error. There's a box in the lower part of your screen. I think it's for.
Part of my screen
It
is
says
covered.
there is a problem with the Office database.
Okay.
Oh, okay, it's going.
Okay, here we go. Okay.
Yeah.
So in this slide, I'm going to focus on secondary causes of hypertension. As you can see, azotemic hypertension, which include glomerular disease, structural kidney abnormalities, dysplastic, hypoplastic, and reflux nephropathy, accounts for approximately 85% of the causes of secondary hypertension in children, followed by renin-mediated hypertension, which includes renal vascular hypertension for about 10%. So in approximately 95% of the cases of secondary hypertension in children are within the kidney, either parenchymal kidney disease, renal vascular, or reflux nephropathy included. The remaining 5%, which is the topic of my discussion today, is endocrine disorders, which includes monogenic endocrine hypertension. One of the most practical and the best way to differentiate primary from secondary hypertension is to obtain urinalysis, basic metabolic profile, renal sonogram, and echocardiogram. Based on the result of this study, if the UA contains hematuria, proteinuria, or increased blood urea nitrogen, serum creatinine, then the likelihood of glomerular hypertension is in order. If the renal ultrasound reveals hydronephrosis, cystic kidney disease, then a structural kidney abnormality is likely the most cause of hypertension, and then requires further workup, including diuretic scan, voiding cystourethrogram to rule out UPG obstruction or vesico-urethral reflux. And then finally, if the patient with hypertension presents with metabolic alkalosis and hypokalemia, the differential diagnoses are renal vascular hypertension and endocrine disorders. And endocrine disorder is the topic, again, of my discussion today. If hypertension is associated with normal UA, normal renal function, normal serum electrolytes, and normal renal sonogram, then hypertension is secondary to essential or primary. So with that basic routine test, a UA, BMP, renal ultrasound, and echocardiogram, we should be able to separate essential hypertension from secondary causes of hypertension. When hypertension is associated with hypokalemia and metabolic alkalosis, the best and quickest approach to differential diagnosis is to order ratio of plasma aldosterone and plasma renin activity. In short, ARR. That's the most sensitive test to arrive to correct diagnosis. There are reported cases in which patients with primary hyperaldosteronism may have a normal plasma aldosterone level. So the diagnosis is going to be missed if we rely on the absolute value of plasma aldosterone and renin level. However, if we get the ratio of plasma aldosterone over plasma renin activity, then it's the most sensitive with 95% accuracy and sensitivity. That takes me to this slide. The most common laboratory features of endocrine hypertension in children present with hypokalemic metabolic alkalosis can be categorized in 4 classes. Class 1, patients with low plasma aldosterone and low renin activity and aldosterone-renin ratio between 10 and 20. If that is the case, we have the following diagnosis: Liddle syndrome, congenital adrenal hyperplasia, apparent mineralocorticoid excess, and Geller syndrome. 2, if the hypertension is associated with high plasma aldosterone level, low renin activity, and ratio greater than 35, then the primary hyperaldosteronism or familial hyperaldosteronism are most likely the diagnosis of secondary hypertension. 3, if a child presenting with hypertension, metabolic alkalosis, and hypokalemia has high plasma aldosterone and high plasma renin activity, and the ratio is between 20 and 30, then Golgi cell hyperplasia is the most likely diagnosis. And finally, patient may present with normal plasma aldosterone and normal plasma renin activity and ratio less than 10, pheochromocytoma, and glucocorticoid resistant hyperaldosteronism, which is Croze's syndrome, is the most likely diagnosis. In summary, when we measure plasma renin activity and aldosterone and the ratio, the patient going to fall in 4 categories. Either both of them are depressed, both of them are elevated, both of them are normal, or aldosterone is high and plasma renin activity is low. There is only one other single endocrine genetic disorder which can present with hypertension, which I have not listed in this table. And that syndrome is associated with hyperkalemia and metabolic acidosis. And that's why I did not list in this table. And that syndrome is called Gordon syndrome. Gordon syndrome is a genetic endocrine disorder, unlike the rest of the genetic disorders present with metabolic acidosis and hyperkalemia. What we have available to differentiate these different genetic disorders, we can use blood and urine exam to differentiate these 4 or 5 different genetic disorders. However, Liddle syndrome there is no specific blood test or urine test to diagnose Liddle syndrome. The only would be genetic analysis. The same is true for Geller syndrome. We have no specific urine or blood test, but there is genetic test to confirm the diagnosis. For patients with congenital adrenal hyperplasia, we can measure the blood for 11-dehydroxycorticosterone and 11-deoxycortisol following ACTH challenge test. For patients with AME, the plasma and urine free cortisol over urinary free cortisol is greater than 1.2. In familiar hyperaldosteronism, the urine test for 18-oxocortisol and 18-hydroxycortisol are elevated. Pheochromocytoma, we have increased catecholamine in the urine and increased metanephrine in the blood. For Crohn's syndrome, there is elevated cortisol and ACTH level, and in 24 hours also we can measure the same. In JG cell hyperplasia, we have elevated plasma aldosterone and plasma renin activity. And in Carney syndrome, we have blood high in cortisol level. For all these genetic disorders, there is a genetic test except for JG cell hyperplasia, which is not still available, as well as for Carney syndrome. Regarding the management of monogenic endocrine hypertension, all of them, except Liddle syndrome, respond to potassium-sparing diuretic spironolactone. Liddle syndrome, which I'm going to talk about later on, does not respond to spironolactone, but it does respond to amiloride or trimethoprim. Patient with congenital adrenal hyperplasia, they respond to spironolactone and also glucocorticosteroid. Patient with AME is the same as congenital adrenal hyperplasia. Geller syndrome, there is no specific treatment. Gordon syndrome, which is associated with hyperkalemia and metabolic acidosis, usually salt restriction and thiazide diuretics would cure hypertension. For familiar hyperaldosteronism, they respond to potassium-sparing diuretic, both spironolactone and amiloride. For paraganglionic carcinoma, the patient do not respond to potassium-sparing diuretics or glucosteroids. The same is true for glucosteroid-resistant hyperaldosteronism, Crohn's syndrome. JG cell must be resected. The tumor should be removed. And for Carney syndrome, also there is a surgical resection of the tumor. Dr. Hooman will be discussing about laboratory investigation and management of monogenic endocrine hypertension in more details. This slide is worth of $1 million. It is a pathophysiology of monogenic endocrine hypertension. I can talk about this slide for over 5 hours, but I'm going to limit it only for 2 or 3 minutes. Under normal condition, let's look at the normal physiology. At the normal physiology, sodium transport is achieved through epithelial sodium channel, which is located on the epithelial cell of the conducting duct tubules. The box represents the cell. On the left side is the urinary space. On the right side, you have the bloodstream space. So under normal condition, the urine sodium will be transported through epithelial sodium channel inside the cell through regulation by aldosterone, mediated by this enzyme, 11-beta-hydroxy dehydrogenase 2, through membrane receptor or mineralocorticoid receptor. As a result, the sodium enters the cell and exits the cell into the bloodstream. The more sodium enters the bloodstream, the more potassium exits and then will be exited and excreted in the urine. In pathophysiology states, let's talk about hyperaldosteronism. We have excessive production of aldosterone. So the membrane receptor for aldosterone will be stimulated and reabsorb all the entry of the sodium into the cell back into the bloodstream. As a result, more potassium will be excreted in the urine and causes hypokalemia and metabolic alkalosis. The excessive sodium reabsorption causes sodium retention, volume expansion, and hypertension. So one pathophysiology is excessive production of aldosterone, like primary hyperaldosteronism and familial hyperaldosteronism. The genetic disorder could be here, located here at the epithelial sodium channel, which mutation of this gene causes hyperactivity of this channel independent of aldosterone. It bypasses the aldosterone. So whatever sodium is in the urine will be entered into the cell and then exit into the bloodstream, causes volume expansion, hypertension. With the excretion of the potassium, it causes hypokalemic metabolic alkalosis. And the third possibility of the endocrine causes of hypertension, the genetic inherited endocrine cause of hypertension, is dysregulation of the mineralocorticoid receptor. It does not respond to aldosterone. It's a non-aldosterone sensitive mineralocorticoid receptor, such as DOCA, such as patient with Cushingoid syndrome. In this case, non-aldosterone mineralocorticoid stimulates the membrane receptors and causes sodium reabsorption into the bloodstream, hypertension, excretion of potassium, metabolic alkalosis, and hypokalemia. Let's talk about a real case. I am presenting to you a 14-year-old boy who was referred to us for evaluation of hypertension. His family history is unremarkable, but he is not sure if his parents or siblings have been diagnosed with hypertension. So we are not sure about the family history. He is on no medication and denies the use of licorice. His urinalysis is normal. Remember, at the beginning, I asked we have to differentiate secondary hypertension from essential hypertension. So we need to get a UA. The UA is normal, no protein, no hematuria. Serum sodium is normal. Potassium is low. Chloride is almost normal, but bicarbonate is on high side. B1 and creatinines are normal. So the patient has a normal renal function, hypokalemia, and metabolic alkalosis. We sent a spot urine for potassium and creatinine, and that was inappropriately high, more than 5. The physical examination showed a well-developed teenager with normal skin, normal eye grounds, and normal peripheral pulses. Blood pressure was elevated. Pulse was 84. Grade 2/6 systolic murmur was heard on the left sternal border, but auscultation of the abdomen did not reveal any bruit, and his neurological examination was normal. Renal ultrasound examination was normal. However, the ratio of plasma aldosterone to plasma renin activity was 14. Conventional blood pressure lowering, including ACE inhibitors, ARBs, calcium channel blockers, with and without thiazide, failed to control the elevated hypertension. Now, the question, all of the following should be considered in the differential diagnosis of this patient except, remember, patient presented with significant hypertension, normal renal function, and metabolic alkalosis, and the ratio of plasma aldosterone over renin was less than 20. The most likely diagnosis is B, because in primary hyperaldosteronism and familiar hyperaldosteronism, the ratio is greater than 30-35. The physician in charge decided to treat this patient with spironolactone. After 10 days, the blood pressure remained elevated, potassium was still low, and bicarbonate did not change. He decided to switch spironolactone to amiloride and waited 2 weeks and repeated the blood pressure. Now is normal, almost normal. Potassium is normal, and serum bicarbonate is also normal. So he cured hypertension, metabolic alkalosis, and hypokalemia with switching spironolactone with amiloride. So I have difficulty search. So it brings me to the next question. With this information in hand, what is the most likely cause of hypertension? All may be, correct. Select all that apply. And the correct answer is D, because the only, monogenic endocrine hypertension which does not respond to spironolactone is Liddle syndrome. And we're going to talk about why Liddle syndrome does not respond to spironolactone. Again, back on that previous slide. In Liddle syndrome, the problem is here. Hyperactivity of the epithelial sodium channel. Abundance of urinary sodium will be entered into the cell, bypassing the aldosterone and entering to bloodstream. So that is why spironolactone is not working, because it bypasses the aldosterone and aldosterone mineralocorticoid receptor. This slide summarizes what I have discussed so far. In summary, a child presenting with hypertension, hypokalemia, and metabolic alkalosis, in the absence of renal dysfunction, in the absence of abnormal ultrasound, we must measure plasma aldosterone and plasma renin activity. That's the best, simple, and quickest way to approach to the final diagnosis. And most preferably, the ratio of aldosterone and renin activity. Then we're going to have 4 categories. Either the patient going to have depressed aldosterone and renin activity and plasma aldosterone renin activity between 10 and 20. The differential diagnoses are Liddle syndrome, AME, congenital adrenal hyperplasia, and if the patient, I'm sorry, I cannot see. Okay, if both aldosterone and renin are depressed and renin aldosterone level is between 10 and 20, Liddle syndrome, AME, congenital adrenal hyperplasia, and Geller syndrome. Liddle syndrome does not respond to spironolactone, but the other, plus Geller syndrome. But the AME, congenital adrenal hyperplasia, they do. But the genetic testing is the most confirmatory addition to arrive to correct diagnosis. 2, patient with metabolic alkalosis and hypertension could have elevated aldosterone and elevated plasma renin activity, and the ratio between 20 and 30. So likely diagnosis is unilateral renal arterial stenosis and JG cell hyperplasia. In unilateral artery stenosis, what we do normally, we get a Doppler renal ultrasound and magnetic resonance angiography, and we make the diagnosis. Patient could have normal aldosterone and normal renin activity and ratio less than 10, then the differential diagnosis would be Croze's syndrome, which is the same as
Sir, sorry, please go for the slide share. Please maximize.
You don't see the slide?
We can see the slides, but they are not in the slide share mode.
Yeah, I see. Because the reason is that when I have one of your screen at the bottom of my screen, which obscures.
Sir, we can go just
okay,
like that. No problem.
Okay, here we go.
So let's go.
Okay, so if the plasma aldosterone and renin activity are both normal and ratio is less than 10, then pheochromocytoma and Croze's syndrome would be in the list of differential diagnosis. And finally, we may have high aldosterone, low renin, and pay attention, ratio of aldosterone over renin over 30 and 35, either primary hyperaldosteronism or familial hyperaldosteronism. the patient that we discussed, his ratio was less than 20. So it fell into the category of low plasma aldosterone, low renin aldosterone level, and did not respond to spironolactone, but did respond to amiloride. So we made the diagnosis of Liddle syndrome without even asking for genetic testing. I would like to thank you for your attention and your interest. Please stay warm and safe, and God bless. Thank you.
Dear Dr. Farahnak, thank you very much for your very nice and educative presentation. I should thank you on behalf of our team and also audiences. As I can see, there are too many private chats that ask me about your slides and if they can have your slides. So if you give us permission, we will send them slides privately to our audiences.
More than pleased to share my slide with everyone who is interested. I have already shared this slide with my nephrology colleagues. All of them have it.
Oh, that's so nice of you. As always, Dr. Farahnak, listening to what you have to say is a great chance for every pediatrician here and around the world.
Say it again, what should I say?
Listening to what you have to say and to your speeches is a great chance for all pediatricians here, and we shall thank you for that.
Oh, my pleasure. You're welcome. Thank you so much as well.
Thanks you. Maria?
Okay, so I would love to personally thank again, dear Professor Asadi, for this awesome, amazing, educational and practical and great lecture that you've given us. Thank you. And it was an honor to have you with us today. So we would love to have dear Dr. Mohkam. Dr. Mohkam, I can see that you're online with us. If you're ready and if you can, if you're available, we will have your slides. Can you hear me, dear Professor?
Good afternoon, good evening,
Hi.
good morning,
Hi.
dear colleagues, dear teachers. Thank you so much for your very nice webinar. I really enjoy it, and thanks for inviting me in this very practical and scientific webinar.
Thank you, dear Professor Mohkam. Thank you. Thank you for joining us.
I really thank my teacher, Professor Asadi, for very great and very scientific and excellent speech. I really use it, and it was very, very helpful for me, and I sure for all of my colleagues.
Thank you, dear Professor. Again, thanks, dear Professor Asadi, and also thank you, Professor Mohkam, for joining us, for accepting our invitation. So, dear Professor Masoume Mohkam is a professor of pediatrics in the Department of Pediatrics in Shahid Beheshti University of Medical Sciences in Tehran, Iran, and we are more than honored to have her with us today and to listen to her amazing lecture. So, dear Professor, I can see that you are a co-host now and you can share your slides whenever you are ready. We are more than happy and excited to listen to it.
I recorded it before, and is it possible for you to present my record slide?
Yes, that's okay.
Maybe there was some problem in my internet, and I'm worried for disconnection.
Yeah, that's sure. Okay, I will play your video. But again, thanks for joining us live again today, and thanks for the lecture. So with your permission, I will play the recorded lecture that we have from you.
Yeah. Bismillahirrahmanirrahim. Good afternoon, ladies and gentlemen, dear colleagues. First of all, I'd like to thank you all for being here in this very important and scientific meeting. And I'd like to thank Dr. Aghai and his colleagues in Tehran University of Medical Sciences for preparing this very important scientific and practical webinar. And I'd like to express my gratitude to my teacher, Professor Asadi, for inviting me in this session. My talk is about management of severe hypertension in children, which is extremely important for all of us who are involved in the treatment and management of these kind of sophisticated and complicated patients. I'd like to start my talk with a case presentation. My case was an 11-year-old girl presented to our hospital with headache, nausea, vomiting, anorexia, and some kind of visual disturbances like blurring and diplopia. At the first part of examination, her blood pressure showed 220 per 180 millimeter mercury, and there was no history of any chronic diseases and any renal involvement in this patient and her family. And unfortunately, she has not been evaluated for blood pressure in her routine physical examination. Her fundoscopy showed grade 4 hypertensive changes, as you can see in this slide, with hemorrhage, Cotton-wool spot, exudate, and papilla edema. And her chest X-ray illustrate cardiomegaly and involvement of the heart. The question is, what are the key aspects of diagnosis and management of hypertension in these kind of patients? As a matter of fact, severely hypertensive patients should be evaluated and treated emergently, especially when the child is exhibiting life-threatening symptoms. Totally, there are no population-based studies on the prevalence and incidence of severe hypertension in children and adolescents, but the result of some studies showed that hypertension in children is underdiagnosed. Severe hypertension in children may present with life-threatening symptoms like pulmonary edema, congestive heart failure, some kind of CNS involvement, eyes involvement, and acute kidney injury. According to AAP guideline, severe hypertension in children is when the blood pressure is at stage 2 with severe symptoms, or when the patient blood pressure is more than 30 millimeter mercury above the 95 percentile for age, when the patient is less than 13 years old, and in patient more than years old, when the blood pressure is more than 180 per 120, we have emergency for a form of hypertension. The most common clinical presentation in severe form of hypertension in pediatric patients are hypertensive retinopathy, hypertensive encephalopathy, some kind of convulsion, signs of left ventricular hypertrophy, somehow facial palsy, visual disturbances and visual symptoms, hemiplasia, and somehow some kind of symptoms in favor of acute kidney injury. As I mentioned before, pediatric hypertension is associated with target organ damage like left ventricular hypertrophy, and carotid intima media thickness is a marker of atherosclerosis, is the other signs for target organ damage, proteinuria, which is a marker of kidney involvement, and encephalopathy or seizure. What are the causes of pediatric hypertensive emergency by age? In infancy period, renal vascular diseases, congenital renal anomalies, and bronchopulmonary dysplasia are the most common causes for pediatric severe hypertension. In childhood, renal parenchymal diseases, renal vascular diseases, and coarctation of aorta are the most common reasons for severe hypertension. And in adolescents, essential hypertension, not adherence to medication. And again, renal parenchymal diseases are the most common etiology for severe hypertension. Based on organ involvement, renal diseases are the most common form of severe hypertension in pediatric patients and in adolescents. And among renal disease, glomerulonephritis, reflux nephropathy, and obstructive uropathy are the most common causes for severe hypertension. Then we have malignancy as the etiology for hypertension. We should be careful about pheochromocytoma, Wilms tumor, and neuroblastoma. And among vascular diseases, coarctation of aorta, renal artery stenosis, and hemolytic uremic syndrome are the most common causes for severe hypertension. Then we have severe form of hypertension with vomiting, high temperature, ataxia, stupor, seizure, and some kind of abnormality in CT scan. We have PRES, posterior reversible encephalopathy syndrome, which is very important in the treatment of patients with severe hypertension. And the risk factor for PRES and neurologic, the other neurologic complication of hypertension in pediatric patients like adolescents and like adult patients are metabolic syndromes, glucose intolerance, dyslipidemia, uremia, atherosclerosis, vasculopathy, anemia, especially hemolytic form of anemia, hypoalbuminemia, thrombocytopenia, and usage of some kind of drugs like cyclosporine and the other drugs. How can we evaluate the patient with severe hypertension? Like the other kind of hypertension, at first, the patient should evaluate by initial investigation and measurement of electrolytes, renal function test, liver enzyme, and doing CBC, drug screening, urinalysis, and in female adolescents, urinary pregnancy test. And about imaging tests, chest X-ray, echocardiography, and renal ultrasonography are the most important form of testing, imaging testing for evaluation of hypertension in pediatric patients. But when we use a specific form of investigation, measurement of metanephrine, cortisol, thyroid function test, complement, and the other serologic tests, and renin activity and aldosterone are very important as second investigation part of hypertensive emergency. And in this situation, using of MRA, CT angiography, DMSR scan, and somehow DTP scan can help us so much for better evaluation of our patient. The goal of treatment for hypertension, severe form of hypertension in pediatric patient is controlled reduction of blood pressure. This is very, very important. And these kind of treatment can help us to prevent more complication, especially ischemic form of complication like neuropathy of optic nerve, transverse myelopathy, and renal involvement. This slide gives us an overview of the evaluation and treatment of hypertension. And about treatment, as you can see, when we have target organ damage, we have hypertensive emergency. And when we have no target organ damage, we have hypertensive urgency in pediatric patients. When we have hypertensive urgency, we can use IV, IM, or PO form of drugs for treatment of patient and control of the patient. But when we have hypertensive emergency with target and organ damage, it's better, and somehow we should admit our patient in PICU and start IV form or IM form of some kind of drugs, and it's better to start infusion form of the drugs for better treatment of our patient. I want to focus on the drug of choice for treatment of hypertension, severe form of hypertension in our pediatric patient. Esmolol, hydralazine, labetalol, and nicardipine are the most important and drug of choice for treatment of severe form of hypertension in pediatric and adolescents. This slide shows us the drug of choice for treatment of severe hypertension in neonatal period. In neonatal patient, ACE inhibitors, alpha and beta antagonists, and calcium channel blockers are the most important and effective drugs for the treatment of severe hypertension. And in this period, especially in infancy and neonatal period, it's better not to use diazoxide and enalaprilate and these kind of drugs because of their severe complications. The other goal for the treatment of, for the better treatment of or best treatment of hypertension in the pediatric patient is close monitoring of the blood pressure. This is very, very important. And to achieve this goal, is better to admit our patient in ICUs, PICUs, especially when we have emergency hypertension. And it's better to use arterial line, especially when we use infusion form of the drugs, especially for sodium nitroprusside and labetalol. I'd like to focus on the onset of the drug effect for treatment of hypertension. For example, when we use nicardipine, the onset is 1 to 2 minutes. For labetalol, the onset is about 2 minutes. For sodium nitroprusside and esmolol, the onset is 1 minute. And for hydralazine is about 10 minutes. And this is very important for better management and monitoring of the patient especially in PICUs. In this slide, we can focus on the side effects of some kind of drugs, especially in pediatric patients. When we use nicardipine, we should be careful about hypotension, tachycardia, flushing, and phlebitis. In usage of labetalol, we should know that labetalol can deteriorate asthma and CHF in our patient, and it's better not to use labetalol in these kind of patient. About sodium nitroprusside, cyanotoxicity, especially in renal failure, is very important. It's better not to use this drug in infants and especially in neonates. And when we use esmolol, which is very important and very effective drug, especially in severe form of hypertension, but in this kind of drug, we should be careful about bradycardia, hypotension, and bronchospasm. And in hydralazine, tachycardia and sodium retention are the most important side effects of hydralazine in treatment of hypertension. This slide shows the onset of hypertension in PO form of drugs in pediatric patients. For example, when we use nifedipine, the onset is about 5 to 15 minutes. For clonidine and captopril, the onset of the effect is about 15 minutes. And for isradipine and for minoxidil, the onset is about 30 minutes. I'd like to sum up the main points of my talk in this slide. Severe hypertension in a child should be evaluated emergently in pediatric patients, and this form of treatment can help us to prevent more complications. And there are currently several available drugs which have been shown to be safe and effective in children, especially in neonate and infant, for the treatment of severe hypertension. I'd like to dedicate this poem of Hafiz to all of you. That day of friendship when we met, recall. recall those days of fond regret recall. Thank you so much for your attention.
Professor Mohkam, thank you very much for your very educational and clear presentation. That was great. Professor Mohkam was one of my beloved professors and teachers during my residency in Shahid Beheshti University. Most of my very good memories from those days belongs to your very good ward in Mofid Hospital. So thank you for today, and thanks a lot for those days.
Thanks for you and for your very nice and very cooperative colleagues, and thanks for all of your effort for preparing this very scientific and very special Congress. And I would like to congratulations to you and all of your colleagues for this very, very important webinar. Thanks a lot.
Thank you very much. Dr. Mohkam, can I ask you just one question? Do you have any experiences with surgical correction of renal artery stenosis in severe hypertension?
Yes, this is a very, thank you so much for your very practical question. In a patient with renal artery stenosis, as Dr. Asadi said before, they are very resistant to multi-drug, and a kind of multi-drug resistance in pediatric patient or patient with secondary hypertension. And renal artery stenosis is a very important cause of secondary hypertension in pediatric patients, especially in patients with lower age, in neonatal period, and in infancy period. And in most of them, it's need to operate patient and correct the stenosis, and they are resistant to usage of multi of the drugs, and it's better to operate them. And when we operate them, someday or some weeks after the operation, we are free of hypertension and no need to the treatment, and it's a good way of treatment for their outcome and for the future.
We had some similar cases here that we have managed them with to Askarian and also the Abbasi here. And we have a very difficult experience with controlling their hypertension. And we go for a stenting of the renal artery and ballooning of them. It was so experiences.
Yeah.
Thank you very much.
Thank you so much.
Thank you very much for your time. I know this is the time of your clinic, so let's go for our next lecture. Thank you very much, Dr. Mohkam.
Thank you so much. Thank you.
Good evening. Maria.
Thank you, Dr. Mohkam, for joining us. We really appreciate it. And I'm seeing the positive comments that I'm seeing in the chat. Everybody's loving all the lectures, and thanks, everyone. Okay, so our next presentation is going to be by dear Dr. Nakysa Hooman. Just let me. Okay, so Professor Nakysa Hooman is a professor of pediatrics, division of nephrology in Ali Asghar Clinical Research Development Center in Iran University of Medical Sciences in Tehran, and we're more than happy to have her with us today. So sadly, Professor Hooman couldn't join us live during this session, but we have a pre-recorded session of her, which I'm pretty sure that you're gonna love.
Hello everybody, I would like to thank the organizing committee that invited me to talk about the monogenic hypertension. I'm Dr. Hooman, the professor of pediatric nephrology from University of Iranian Society of Medical Science. The monogenic disorders of hypertension are a subgroup of a genetic form of hypertension. That's the gene gain of function or loss of function in the three main pathways, the pathway of mineralocorticoid, glucocorticoid, or sympathetic pathways. Monogenic hypertension is a specific genetic hypertension disorder that transmitted and obey of the Mendelian inheritance and actually inhibit the normal regulation of blood pressure by renal or adrenal. And the main characteristic of this disease is low plasma renin activity. The prevalence of childhood primary hypertension has been determined between 2.2 to 9%. That is more founded in Iranian registry or surveillance has been done in Caspian study. But about monogenic hypertension, we do not know exactly what is the percentage, and all are reported from the outpatient clinics, or some study has been done on a specific disease and has been reported between 1.5% to 3.1%. The monogenic hypertension can be divided into three subgroups. The first group has been associated with excessive aldosterone synthetases that included familial hyperaldosteronism. The second subgroup is a dysregulation of metabolism and action of adrenal steroid that included actually four main sub-disease named apparent mineralocorticoid excess, congenital adrenal hyperplasia, activating mineralocorticoid receptor mutation, and primary glucocorticoid resistant. And the third category included the hyperactivity of NaCl transporter in the distal tubule that contained two main diseases, including Liddle syndrome and pseudohypoaldosteronism type 2. The main question is, when we suspect to monogenic hypertension in order to want to evaluate more. Family history and physical examination and some main laboratory tests might be some clue in order to think about the monogenic hypertension. Familial history of early onset stroke, the presence of resistant hypertension to medications, and the presence of dysregulation of potassium, including hypokalemia or hyperkalemia, metabolic acidosis or metabolic alkalosis, and if we find some abnormality in physical examination, for example, the presence of muscle weakness, history of polyuria, delayed or precocious puberty, growth failure, ambiguous genitalia, or virilization. We have to think about the monogenic hypertension and to evaluate it. But first, we have to exclude renovascular hypertension and all parenchymal disease that cause hypertension. This is a simplified flow chart of diagnosis and management of early onset monogenic hypertension. If we encounter a child that has early onset hypertension started at early age, we should check renin level. If renin level is high, so we could exclude monogenic hypertension and we think about renal artery stenosis and something like that. But if the renin level is low, then we have to check aldosterone. If aldosterone has high level, we should use glucocorticoid in order to suppress it. If it's does not suppress, so it should be familial hyperaldosteronism type 2 or 3. And if it responded, it should be familial hyperaldosteronism type 1. If aldosterone level is normal, then we use a mineralocorticoid receptor antagonism, such as spironolactone. If the response does not occur, so we should think about Gordon syndrome. And the third group, those who have aldosterone level that are lower than normal. We use again mineralocorticoid receptor antagonism and check the response to it. We check that if blood pressure has been controlled or not. If does not respond to mineralocorticosteroid antagonism, so we could think about Liddle syndrome. And if this responded, we should check desoxycortisol to cortisol ratio level. And if the ratio is low, the apparent mineralocorticoid excess come to the top of the list. And if it's high, the ratio is high, we should think about congenital adrenal hyperplasia that usually accompanied with some abnormality in physical examination. Now we a little talk about more in detail these specific disease. The first group are those that have associated with excessive aldosterone synthesis. So aldosterone level in this group of patients are high. These patients named familial hyperaldosteronism and categorized into 4 groups. And the main pathological problem is in the zona glomerulosa. And the most common of this subtype are those have a gene mutation or gene disorder that has hybridation of the 2 genes of CYP11B1 and CYP11B2. CYP11B1 actually produce the protein of 11-hydroxylase and CYP11B2 actually produce aldosterone. And this merge and hybridization of these 2 genes causes that, because it is not the equal part, the production of aldosterone is much higher. The other subtypes include disorder in the canal of chloride, potassium, and calcium. All of these cause depolarization of the cell and finally reach to the production too much aldosterone. The first subtype that has hybridization of these 2 genes that produce aldosterone and cortisol actually is under the control of ACTH. ACTH combined to this receptor and cause that these genes CYP11B1 more activated and produce more steroid, and the final of this activation is more aldosterone production and sodium resorption and retention and hypertension. This group called apparent mineralocorticoid excess of aldosteronism. So when we are suspected to monogenic hypertension, we measured renin and is low and the potassium level is normal or low. We should measure the ratio of aldosterone to renin. This is very important because sometimes in this kind of the patient, the potassium level is not very straightforward and could be in the normal level, and even the aldosterone and renin separately to be interpreted could not be helped. If the ratio is high, and for adult patient, the cut point is more than 30, and for adult is more than 10, familial hyperaldosteronism should be considered, type 1 to 4. And as I told, there are 4 mutations that included 1 gene hybridation and 4 channel that has dysfunction. In this case, we have to study the abdomen, especially adrenal, with CT scan or MRI of the abdomen. This is a table that summarizes the age, the protein, the way of inheritance, and the clinical manifestation and diagnostic study, and the main therapy has been suggested for the familial hyperaldosteronism type 1 to 4. As you can see, the inheritance in all of these subtypes are autosomal dominant, and the age of onset could be variable between infancy to early childhood or even adulthood. And the severity of hypertension could be between moderate to severe or severe hypertension. And the potassium level could be even in normal level or low. So potassium level could not be a main clue in order to suggest monogenic hypertension only. The clinical manifestation besides of hypertension could be in the type 1, sometimes there are intracranial aneurysm and early onset stroke. Occasionally, we could find bilateral adrenal hyperplasia. In type 2, that has especially CLCN2 gene has disorder, that is a voltage-gated chloride channel. The adrenals actually imaging are normal, but rarely we could find unilateral nodule or mild hyperplasia that has been reported rarely in 2 cases. In type 1, if we a high ratio of aldosterone to renin exists, actually this high ratio can be found in all of these 4 subtypes. But the main point is that if we use dexamethasone suppression test, type 1 and type 4 would be respond, but type 2 and type 3 would not respond. The aldosterone level could not be reduced. In type 2 and in type 3, that is abnormality in the potassium channel that has G protein activated of recipitier potassium channels, has bilateral hyperplasia, especially in those who have severe hypertension or severe form, sometimes present with polyuria and have metabolic alkalosis. And in the final group, type 4, that has voltage-gated calcium channels, these cases usually have some mental disorders. For example, attention deficit disorder, developmental delay, or even seizure. Genetic study is the only confirmatory test that can help us in order to find the real diagnosis. And the therapy, usually we can use mineralocorticoid receptor antagonism or ENaC blocker, and in those who suppress with steroid, we can give low dosage of steroid. So, besides that measurement of aldosterone to renin ratio, we use dexamethasone suppression test that we give 0.5 milligram every 6 hours for 4 days. Then we measure plasma aldosterone. If it's suppressed to lower than 4 nanogram per deciliter, and 24-hour urinary corticosteroid metabolism is more than 10 nanomole per liter, we suspect to especially JRA, and the management would be given low dose of steroid, for example, dexamethasone, 8 to 10 milligram per square meter per day, or hydrocortisone, mineralocorticoid receptor antagonist, such as eplerenone or spironolactone, and INAC antagonists, for example, amiloride or triamterene. But we should keep in mind that ACE inhibitor and beta blocker has no role or no efficacy in these cases. Second group in the monogenic hypertension are those have dysregulated adrenal steroid metabolism and action that have included 4 main diseases. The first is apparent mineralocorticoid excess that has a specific gene. It has a HSD11B2 that produce 11 beta hydroxysteroid dehydrogenase 2, and in this disease this protein would not be produced. We lack it, and the inheritance is autosomal recessive. The age of onset could be from infancy to early childhood. There have 2 subtypes, 1 and 2, and 2 is milder and present in the older age. And the patient can be even have low birth weight, growth failure, polyuria, and severe hypertension. Because 11 beta hydroxysteroid dehydrogenase type 2 has a main role in conversion of cortisol that has active to inactive form of cortisol. And because of inactivity of this protein or enzyme, the level of cortisol increase. It has some mineralocorticoid activity, so attached to mineralocorticoid receptor, and the final pathway would be the more absorption of sodium from the INAC and excretion of potassium from RAMK channels. For diagnosis, we use the main laboratory test. We usually have metabolic alkalosis, nephrocalcinosis, and hypercalciuria, and markedly the potassium level is low. But remind that potassium level could be low but milder in type 2. So we should not be confused with normal level of potassium in order to ignore this kind of disease. Urinary steroid metabolites are high, more than 1, and free cortisol to cortisone is more than 0.5. The main therapeutic treatment that has been suggested is mineralocorticoid receptor antagonist, INAC blocker, and dexamethasone. The second disease in these subtypes is congenital adrenal hyperplasia, that the main gene of CYP17A1 and CYP11B1 that has the main gene that produce the protein of 17 alpha hydroxylase and 11 beta hydroxylase. The absence or deficiency of these 2 enzymes cause accumulation of more progesterone, reduction of aldosterone, and accumulation of desoxycorticoestrone. Age of onset in CYP17A1 is around adolescent, and in CYP11B1 is around childhood. The inheritance is autosomal recessive. So if we get family history from the parents, they may have normal appearance and normal blood pressure. Clinical presentation is a little bit different. Hypertension could be variable, normal, high, or even severe. In CYP17A1, there is delayed puberty and sexual infantilism. and CYP11B1, there is ambiguous genitalia, short stature, advanced bone stage, and precocious puberty. So they are exist in the end of the spectrum, from delayed puberty to precocious puberty. For diagnosis, if you measure potassium could be low in CYP17A1 defect. But the main screening hormone that has been suggested is measurement of cortisol that is low level in the morning. In CYP17A1, the level of progesterone relative to 17 alpha progesterone is high, and CYP11B1, the level of 11 desoxycortisol to desoxycortisone is high. The main treatment is using hydrocortisone and replace the steroid deficiency, and if required, we use mineralocorticoid receptor antagonism in order to treat the hypertension. Geller syndrome is another disease that has the other name of the mutation that activate the receptor of mineralocorticoid. Actually, the gene is NR3C2 that has gain of function, so the activity increased, receptor has more affinity or activity. The inheritance is autosomal dominant, and the presence of age is between adolescence to adulthood. A patient can present with severe hypertension, and the main clue that could guide you in order to think about is that the hypertension exacerbated in pregnancy, and if you use spironolactone to treat the hypertension, the blood pressure exacerbated. Because if we look at this schema, we can see that the mineralocorticoid receptor that I highlighted yellow has more activity, and the final pathway is more INAC and more sodium absorption and retention in the distal tube. The diagnosis is only actually genetic study that help us, and the other clinical sign and laboratory test that I told. The potassium level could be low, but the treatment has two main medication that has been suggested. INAC blocker and finerenone could use as a management for this disease. In the primary glucocorticoid resistant that has been flashed with a yellow flash or cursor I have been showed here, the resistance to glucocorticoid exists. The gene of that has a role in this disease is NR3C1 that produce their glucocorticoid receptor. The inheritance could be autosomal dominant or autosomal recessive, and the age of onset usually is started around adulthood, but rarely around children between 2 to 12 years of old has been reported. Has presented with severe hypertension, and the main clue in these cases are adrenal hyperplasia, virilization, poor growth, and precocious puberty. If we measure potassium in this patient, it could be in the normal level or low. There are sometimes hypoglycemia, metabolic alkalosis. The level of free cortisol in the urine is high, and after overnight suppression with dexamethasone, the cortisol level is more than 50 because of the resistance exist. And for treatment, dexamethasone and metal MRA, if required, we suggested. The final group of this monogenic hypertension classification, those has hyperactivity of NaCl transporter in the distal tubule that has included two main diseases. The first one is Liddle syndrome that has three subtypes, 1 to 3, and three different genes that involved SCNN1B, 1G, and 1A. That produce the protein that has a role in the ENaC formation. The inheritance is autosomal dominant. The age of onset differ between late childhood to adolescent, but can occur at any age. The clinical presentation could be included usually severe hypertension, but we should consider that sometimes blood pressure is normal in these cases. But in 90%, you can find a positive family history of hypertension. For diagnosis, we usually measure potassium, but it could be normal or low level. And urinary aldosterone level is usually lower than 5 microgram per day, or even the metabolic of aldosterone. And metabolic alkalosis usually exists. And if you see in this panel, you can see that actually sodium retention increased because of the ENaC channel has been activated. So if we use ENaC blocker, for example, amiloride or tiramturan, we can treat in these cases. In patients who have hypertension, renin level is low, but there is hyperkalemia. The only cases that in these groups that I have talked about have hyperkalemia, not hypokalemia or normal kalemia, is Gordon syndrome or pseudo-hypoaldosteronism type 2 that included 4 main genes: WNK1, NK4, CUL3, and KLHL3. These genes are showed actually in this distal tubule, and WNK1 has actually activity role on potassium channel in order to secrete potassium into the lumen of urinary lumen, and has activity role on ENaC in order to reabsorb sodium from sodium channel. WNK1 has actually an inhibitory role on WNK4. WNK4 usually cause more chloride reabsorption and has inhibitory effect on ENaC. In the Gordon syndrome, there is loss of function of WNK1 and gain of function of WNK4. So, because WNK1 does not work, so potassium channel dysfunction and potassium retained and cause hyperkalemia. But because WNK4 gain of function, there has more sodium reabsorption and chloride reabsorption. And the end of this activity is hypertension. So we've got hyperkalemia. Potassium level is between 8 to 9 milliequivalent per liter. There are sometimes periodic paralysis, metabolic acidosis. The aldosterone level could be low or normal, and renin level is low. The management could be, if the blood pressure is high, but it's in the mild level, we can restrict sodium consumption. But if it's higher, we can use thiazide because it blocks sodium chloride channel. This table summarizes the phenotype-genotype correlation in Gordon syndrome. As we can see, the hypertension exists in all of these 4 groups. Hyperkalemia could exist in different level, but there are in all of them. Metabolic acidosis even exists, but in WNK4, They usually accompanied with hypercalciuria, hypocalcemia, decreased bone mineral density, and renal calcium stones. And in CUL3 deficiency, there is fertility affected, and there are growth impairment. One of the main important thing in one of the main important point is that the severity of hypertension and hyperkalemia and metabolic acidosis varies according to different mutation. It's more severe in CUL3 and then decrease gradually according to the in term to recessive KLHL3, dominant KLHL3, then WNK4, and finally WNK1 has the less severe form of disease. So when we are suspected to monogenic hypertension, renin level is low, potassium level is normal or low. We measure aldosterone to renin ratio. If it's low or normal, we should check for congenital adrenal hyperplasia, and the gene you can see, apparent mineralocorticoid excess, Liddle syndrome, activating mineralocorticoid receptor mutation, and glucocorticoid resistant. And the main point is that the confirmation of this disease actually is by a panel of monogenic hypertension that assess all of these genes. In summary, you can see the main disease of the monogenic hypertension, those that are affected only adrenal gland, that included apparent mineralocorticoid excess that has activity of cortisol, that has more mineralocorticoid efficacy, and activated the MR receptor, and more sodium reabsorption from NaCl and sodium channel. The second group is JRA, that has more aldosterone synthesis and or excess that affect on MR receptor and has the same sodium retention effect. The other two main disease, those has effect on distal tubule. The Liddle syndrome, that has gain of function of sodium channel, that in the atypical sodium channel cause more sodium retention, and the Gordon syndrome that actually has more sodium retention and loss of potassium excretion. In this panel, you can summarize all of the disorder and the main actually test and physical exam that you can use, and in order to reach to the some disease that's suspected. And I do not go through it and just put it in order to use as a guide. Thank you for your attention, and I'm here in order to ask any question if there is.
Okay, I would love to thank dear Professor Hooman for her amazing lecture. We had another speaker, dear Dr. Seyedzade, which was going to talk about hypertension and smoking and passive smoking in children. But sadly, due to a limitation of our time, because our next session is going to start in 10 minutes, we have to omit that, but we will upload it on our website, and you can listen to his amazing lecture on our website. I would love to thank again all of our audiences, all of our guests for this amazing and for joining us, and also our awesome and amazing lecturers. Again, dear Professor Asadi, dear Dr. Hooman, Dr. Elaheh, Malekan-Rad, and also dear Dr. Mohkam for joining us again tonight. It was really informative and really great and we thank you for joining us. Again, I would love to say that for our Iranian audience, if you have registered on the IRCME website to obtain CME credit, you have to participate in the exam after this session is over. And for all of our audiences who want to receive certification of attendance for this meeting, you have had to register on our website. So with this, I will finish this amazing hypertension session. Again, I thank you for joining us, and we will have a 15-minute break, and then we will start our neonatology session. Thanks, everyone, and I'll be back in 15 minutes.
Thank you very much. It was really great.